Now let's have a look at how we control plasma lipids. And before we do that, let's just have a little chat about whether we should control plasma lipids. I think we do need to address the whole issue of cholesterol and heart disease and what the relationship is between the two, because it's important when you're studying these drugs to be able to put the pharmacology in the context of our current knowledge of the public health and the epidemiology. Now, as with most areas of medical research, as research continues, we get a more and more detailed picture, and we are able to dissect more and more precisely exactly what's going on. In the case of cholesterol, what we have known for some time, and what appears to be in no doubt whatsoever, is that plasma LDL levels are positively correlated with cardiovascular events in the population. That is to say that as LDL levels rise, you get a rise in heart attacks and strokes. Not all of them fatal, of course, but you see an increase in the incidence of those events as LDL levels increase. And therefore, it stands to reason that if you can intervene and reduce LDL levels, you can reduce the number of cardiovascular events occurring in the population and therefore reduce the risk in any individual. Now, as we've already seen, there are a number of cardiovascular risk factors that we've already looked at. And obviously, if you add high LDL to other existing cardiovascular risk factors, then the risk of a cardiovascular event is going to be higher. So you have to look at cholesterol levels and LDL levels in the context of other cardiovascular risk factors. But when you do that, what you find is for both high risk and lower risk, reducing LDL reduces the risk of cardiovascular events occurring. And there's been quite a lot of controversy about how aggressively and in how many people should we be trying to reduce cholesterol levels. And the controversy has swirled around mainly the major group of drugs that we use to reduce cholesterol levels, and that is the statins, which we're going to look at shortly. Part of the controversy is because, like almost all drugs, the statins do have some adverse effects. They have comparatively few adverse effects, and of those adverse effects, the serious adverse effects are relatively rare. But they have received some very bad publicity that was biased and non-scientific, and as a result of that, a certain amount of fear has been instilled in the public, particularly in Australia, about the statins, which has led to people coming off statin therapy. And there have been arguments about, is there a relationship between cholesterol and heart disease, or are we just selling drugs in order to make money? Is it to anybody's benefit to take drugs which lower cholesterol? How will it help? As the investigation on the lipoproteins proceeds, as research always does, reveals more and more about the different types of lipoprotein. And what we know is, as I've just said, there is an increased risk for cardiovascular events if you have an elevated LDL level, but there also seems to be an increased risk if you have a reduced HDL level. Now that makes sense based on what we've said about lipid metabolism and what the role of HDL versus LDL seems to be. But there's something else that has come into the story more recently, and that is there are a number of different types of HDL. And remember, we looked at the various different functions of HDL. We now know that it's more than simply a vehicle for taking cholesterol out of the circulation, out of cells, and back to the liver so that it can be dealt with there. HDL does more than that, has a lot of beneficial effects in the circulation. But now what we're seeing is HDL has to be functional in order for those beneficial effects to be felt. And so it's not enough to say we need to raise HDL levels to bring about those protective effects. We need to ensure that the HDL that we're raising is functional HDL and not abnormal HDL. So as usually happens when we get more and more research into an area, the picture becomes much more complex, the nuances become much finer, and it becomes much more difficult to come out with a one-line public health message. But what is clear is that the use of drugs like statins in people who have existing cardiovascular risks, for example, older age, hypertension, has reduced the incidence of heart attacks and strokes, and therefore deaths. And the adverse effects of the statins have been, by and large, overstated. I'll quote to you some statistics from an American study. After crunching the numbers on the adverse effects, and they did a number of meta-analyses on various different studies, they found that if you've treated 10,000 patients for 5 years with statins, you would expect to see one case of rhabdomyolysis, which is breakdown of skeletal muscle cells. That's a serious side effect, but one case in 10,000 patients in 5 years. 5 cases of myopathy, which again is muscle dysfunction, which is also quite serious. 75 cases of diabetes, that's new cases of diabetes, and 7 hemorrhagic strokes. So all of those things are rarely associated with statin use. The rate at which you'd expect to see them would be 10,000 patients treated for 5 years, 75 diabetes cases, 7 hemorrhagic strokes, 5 cases of myopathy, and 1 of rhabdomyolysis. On the other hand, of those 10,000 people treated for 5 years, 1,000 heart attacks and strokes would have been avoided in people who would be considered at high cardiovascular risk amongst that group, and another 500 avoided in the people who would be considered lower cardiovascular risk in that group. So that's a total of 1,500 heart attacks and strokes not happening due to the use of the statins, as opposed to 88 cases of serious adverse effects. The control of blood lipids is saving lives and reducing cardiovascular risks. The question is which drugs you use to do that, and as you'll see when we do a quick review of the drugs that are currently used, the statins are extremely effective drugs. One thing I will say from some of the studies is that studies that have reported looking at adverse effects when the trials have been blinded, in other words, nobody knows whether they're taking the statin or a placebo, the reporting of the adverse effects are roughly equal in the placebo and the drug group. But when you've got a double-labeled study where the subjects actually know whether they're taking a statin or something else, you find that the reporting of adverse effects with the statins suddenly increases over the other drugs. So there is an element of people expecting to suffer adverse effects, which are actually very rare, but they will perceive and report adverse effects if they know they're on a statin. So there's been some misinformation. It's been a bit of a changing landscape with cholesterol and particularly with the statins, and there's more obviously to come. But what is clear is that the use of statins in both people who have relatively high cardiovascular risk and people who have lower cardiovascular risk is reducing the incidence of heart attack.